All right, so today we start our section on mediastinum. We'll talk about the boundaries of the mediastinum, differential diagnosis, et cetera, et cetera. So in terms of dividing the mediastinum into the various compartments, uh, I find that the Felsen classification is the most useful to use if we're going by the chest radiograph. So we divide it into anterior, middle, and posterior. So the anterior mediastinum, we draw a line from the anterior border of the trachea down posterior to the heart, and then we draw a second line 1 centimeter posterior to the anterior border of the vertebral bodies. So everything anterior to the first line is considered anterior mediastinum. Everything between the two lines is middle mediastinum, and posterior to this second line is posterior mediastinum. Notice that in this classification, it puts the heart in the anterior mediastinum, although anatomically we think of the heart as being in the middle mediastinum. It's also important to realize that these divisions of the mediastinal compartments are purely arbitrary, that there are no fascial planes that actually separate one mediastinal compartment from another. But if you're looking at the chest radiograph, and as we go through the differential diagnoses for the different mediastinal compartments, I find that this approach using the chest radiograph is most useful. So again, comparing the Felsen scheme to the anatomic scheme, so in the anatomic scheme, the heart is placed in the middle mediastinum, and you also have the trachea in the middle mediastinum, but the esophagus in the posterior mediastinum in the anatomic scheme. So the problem with that is if you have masses, let's say in the middle on the lateral chest radiograph, I don't think you want to be talking about posterior mediastinal masses here. So I think here you want to talk about middle mediastinal masses. And so that's why I find that the Felsen scheme of drawing the line back here is most useful. Now there is an official classification of the mediastinal compartments put out by a society. This is the International Thymic Malignancy Interest Group classification of the mediastinal compartments, and this is based on the appearance on CT. So if you're asked questions as far as exams about the different compartments of the mediastinum, this is the scheme that you have to use. And in this scheme, instead of anterior, middle, and posterior, they call it prevascular, visceral, and vertebral. So you'll see that the prevascular, or what we refer to as the anterior mediastinum, is out here, and it's colored for you on the sagittal view and on these axial views. And then they do put the heart in the visceral compartment, or the middle mediastinum. So if you're asked questions on examinations, this is the scheme that you need to use. Although I find that, since this is based on CT, if you're actually looking at a CT scan for trying to differentiate where a mass is, you actually see it laid out for you. It's not as difficult as on the chest radiograph. So I find that the Felsen scheme is most useful when you're dealing with the chest radiograph. So the prevascular, or the anterior, here it is here, anterior to the heart. And then we have the visceral, or the middle, that's in here. And then the vertebral is back here next to the vertebral body. So you think of this as anterior, middle, and posterior mediastinum. So that is the official classification if you're asked any questions on examinations. So with this chest radiograph, what are the findings here? What do we got? Well, what do we see? Let's go through the findings first. Yeah, so we have the deviation of the trachea towards the right. So there's a mass here that's producing deviation of the trachea. On the lateral view, can you tell where the mass is? Yeah, so here it is. You can see this abnormal soft tissue density there anteriorly. So what do we think this might be? So why do we think of thyroid first?
There's a deviation of the trachea.
Yeah, so whenever you have deviation of the trachea towards the right like that, and you have a mass that's extending down from the neck, extending down from the thoracic inlet, So this is where you have to think about thyroid masses first. Occasionally, you might have like massive lymphadenopathy that might simulate this, but the first thing you have to think about is thyroid masses. And then there's another finding on the front of you. As you follow the lateral border of this mass up towards the neck, what do you notice about it? Well, it's not as distinct, right? It's not as clear up here as it is down here. What do we call that?
Cervicothoracic.
Yeah, it's a cervicothoracic sign, which helps to point to the anterior mediastinum. So here's the CT, and the CT demonstrates that this represents a what? Yeah, so this is a thyroid mass. Now, how do we know on CT that this mass is a thyroid mass? Exactly, right. So the most important thing is that you want to connect it to the thyroid. So you follow it back and you see that it connects to the thyroid. In terms of the attenuation, it is mixed attenuation, and goiters can have mixed attenuation like that. There also be portions of it that are increased in attenuation. That could be on the non-contrast also, because remember the thyroid concentrates iodine. Also, the thyroid is vascular, so if you're given contrast, you will also see some marked enhancement. In terms of deciding whether this is benign or malignant, you can, whenever you have large masses like this, you can never be 100% certain. But the features here that point to this being benign are what? What's that? So the vessels are pushed away, right? And you see that there's a very nice boundary between the mass and the surrounding structures, okay? So there's no overt signs of invasion as you're looking at the CT. But again, you know, that rule is not 100% reliant. You do have to ask the patient, how long have you had this? Has it been growing rapidly recently, et cetera, et cetera. But those are features on the imaging that, at least you don't have any features on the imaging that definitely tell you that that's a malignant mass. So the finding on this chest radiograph, what do we have?
With a negative cervicothoracic sign, deviation of the trachea.
Yeah, so again, we have deviation of the trachea towards left. On the lateral view, where's the mass?
Posterior trachea.
Yeah, so the mass is here, posterior to the trachea. So what compartment is that? Well, we just went through the compartments. What compartment is that going to be?
The middle.
Yeah, that would be the middle mediastinum. So what would you entertain as differential diagnosis for this mass?
It could still be thyroid.
Okay, so why do you think it's thyroid?
Because again, it looks like we have the cervicothoracic sign, so it's coming up from.
The most important feature that points to this being thyroid is what? Deviation of the trachea. Again, you have a mass that's coming down from the neck, right? Again, the cervicothoracic sign there, but it's coming down from the neck and it's deviating the trachea. Whenever you see that, you think thyroid mass is first, even though it's extending there to the middle mediastinum. And these thyroid masses can extend down the paratracheal region. In most cases, they extend to the anterior mediastinum, but they can also extend down posterior to the trachea there, to the middle mediastinum. So you shouldn't let that appearance fool you. If you see that the mass is deviating the trachea, you do have to think about thyroid masses. So again, here you know the drill. What do we have?
Anterior mediastinal mass.
Yes. What's it doing?
There's a tracheal deviation.
Right. There's tracheal deviation towards the right. Okay. Here on the lateral view, you can say it's in the anterior mediastinum. Again, notice cervicothoracic sign there, the lateral border we don't see above the clavicle. So in your differential diagnosis, you will start with thyroid mass, right. Here's the CT on this case. There's something different about the appearance here than what I've shown you before. What's different?
Looks like the mass encases the vessel.
Yeah, this time, instead of pushing the vessels aside, the mass is encasing the vessels. You see how it's growing in between the vessels, pushing it aside. Other things that might worry you is a pleural effusion, so what's going on there. But in this case, the mass is encasing the vessels, not pushing them aside. So here, what do you think this is going to be?
Like a malignant thyroid mass.
So here you, again, it connects to the thyroid, so it is a mass of thyroid origin. So here you're thinking malignancy, all right? So here you have to be suspicious about thyroid cancer. All right, so we've discussed the thyroid goiters. They can extend down usually into the anterior mediastinum, but as we've seen, they can also extend to the middle mediastinum. The path of extension is important. If it's anterior mediastinum, then cervical incision, they can remove it, as opposed to middle mediastinum that would require stenotomy to remove the mass. The most important feature when you have a mass extending down from the thoracic inlet, deviation of the trachea, so that points to thyroid, so you're going to think of thyroid masses first, if that's something that we see, all right? So we've gone through the appearance of thyroid goiter here, connects to the thyroid, can be increased in attenuation. These are vascular, so if you give contrast, you're going to see marked enhancement here with these lesions. Benign goiters will push vessels aside, they will not invade vessels. So if you see encasement, if you see lymphadenopathy, if you see blurring of margins, then you're going to be more concerned about malignancy. Okay? So then, as we've seen, they can extend to the middle mediastinum posterior to the trachea, as in that case. But if there's encasement of vessels, if there's lymphadenopathy, then you are going to be concerned about malignancy when we see these things. Right? Chest radiograph, does everybody see where the mass is? Where's the mass? Right side or left side?
Left.
Left, okay, good. So we see this big mass here. Now there's a wonderful plain film sign that is illustrated here. What is the sign that's illustrated? Yeah, so what is the hilum overlay sign? What is it?
You can see
You can see the left pulmonary artery through the mass, okay? So that's important because that helps you to localize the mass just from the frontal chest radiograph. So where do we think this mass is based on the appearance of the frontal chest radiograph?
could be anterior or posterior.
So the first thing is it's not going to be in the middle because it's not obscuring the left hilum. So now you're thinking it's either anterior or posterior. Now can you take it further than that? How do you decide which of those it is?
Looks like it's silhouetting the left heart border.
Yeah, so it is silhouetting the left heart border. The heart border we think of as, that's an anterior structure, right? What is it not silhouetting? The descending thoracic aorta, right? So here you can see it's a hilum overlay sign. It's not in the middle. It's not silhouetting the descending aorta. It is silhouetting the left heart border. So now, just from the frontal radiograph, we've localized it to anterior mediastinum. If you want to be sure, you want to see.
Lateral.
There's your lateral. Where's the mass?
Anterior.
Anterior. There it is. What is your differential for this?
Thymoma.
Okay, so you could start with thymic lesions, right? Do we like thyroid for this?
Possibly. No.
Possibly, no. Which is it?
No, anterior
No, we don't like thyroid. Why don't we like thyroid for this?
one, it's not pushing against the trachea.
Yeah, it's not deviating the trachea, and it doesn't look like it's extending down from the neck. All right, so we don't like thyroid for this. So we've started with thymoma. I mean, there's your, what is the differential for anterior mediastinal masses? The classic is,
Teratoma, terrible lymphoma.
so that we call that,
T's.
yeah, the T's. How many?
4.
4, they are, just to go through it. Thyroid, come on.
Thymoma, terrible lymphoma, teratoma.
Now, I've been told if you meet somebody at a cocktail party and they tell you they're a doctor, if you want to be sure, ask them for the differential. What are the 4 T's? If they're a doctor, they can tell you that. Okay. And of those, right, the one that we eliminate is,
Thymoma.
we eliminate thymoma?
Oh, well.
Of those, we've said thyroid is the one that we don't like. So here's the CT on this case. We have this well-defined anterior mediastinal mass. If there's a clinical question you'd want to look into, what is that for this patient? Yeah, so you'd want to know about myasthenia gravis. And this patient did have myasthenia gravis, therefore this is a thymoma, right? This turns out to be a thymoma. Again, those other things can be in the differential diagnosis, but with the history of myasthenia gravis, that's what you're going to worry about. Here again, there's an anterior mediastinal mass. There's another finding here that really helps you in terms of what this might be. What's the other finding?
It's like a pleural metastasis.
Yeah, so you have these pleural lesions, right? So these are drop pleural metastases. So if you see these in combination with an anterior mediastinal mass, the first thing on our list becomes invasive thymoma, right. So this is a malignant thymoma. This is invasive thymoma. So with invasive thymoma, the mode of spread tends to be inside the thorax and it spreads to the pleura. So if you have pleural metastases with an anterior mediastinal mass, then we think of invasive thymoma. So thymomas are associated with paraneoplastic syndromes, myasthenia gravis. 10 to 23% of patients with myasthenia gravis will have thymoma, 30 to 50% of patients with thymoma have myasthenia gravis. There are some other rarer paraneoplastic syndromes that can also be associated with thymoma. Okay. Focal mass, anterior mediastinum, they may have calcifications. It is spread beyond the capsule that determines whether it's invasive or non-invasive. We can't always tell by imaging. If there are findings like pleural metastases, then of course you're going to be thinking about invasive thymoma, and about 30% of these can be invasive. So it's in our differential for an anterior mediastinal mass. It's another example of a very nice thymoma here. On that example, what are signs that suggest that it's malignant? Irregular margins, encasement of vessels, these are all kind of obvious things. Irregular interfaces, extension across the midline, of course, drop pleural metastases. These rarely metastasize outside the thorax. So metastatic disease is usually confined to the chest when we have these invasive thymomas. Okay. Another type of lesion is thymic carcinoma. This is histologically distinct from invasive thymoma, but this is also malignant. This is rarer than invasive thymoma. These tend to be more aggressive, so these can be associated with metastatic lesions at the time of presentation. They can invade vessels and adjacent structures, and they can have mediastinal lymphadenopathy, and you can have hematogenous Mets with thymic carcinoma. So these are more aggressive looking lesions. This one's an anterior mediastinal mass here. You can see the effect on the superior vena cava. So invasion of great vessels, lymphadenopathy, phrenic nerve palsy, hematogenous metastases, all of these can be associated with thymic carcinoma. Okay? Here's a 37-year-old man with myasthenia gravis. There's an anterior mediastinal mass. So our first thought here is right, so our first thought is thymoma, right? But there is something we can do to evaluate these anterior mediastinal lesions a little bit better, and that's illustrated here. So what is it that we're doing here?
You have an out-of-phase imaging on the top left.
Yeah, so it's which one is out of phase, which one is in phase?
Top left is out of phase.
Yeah, so this one's the out of phase image, this one is the in phase image. So very similar to how you would evaluate adrenal lesions at 1.5 Tesla, you're in and out of phase every 2.2 milliseconds, okay? So what do we see regarding this lesion? What does it do?
Loss of signal.
There's loss of signal here on the out of phase image, and how does that help you? What is your conclusion then from looking at this?
There's that microscopic fat, so I'm more likely like thymic hyperplasia.
Yeah, so this, when we see this, then we think of benign lesions. So in this case, thymic hyperplasia, which is can also be associated with myasthenia gravis. Okay, so you would not expect the malignancy to drop out that much out of phase. When you're trying to decide whether the signal is dropping out just visually, looking at it, what is it that you do? How do you decide if the signal is dropping out? I mean, I know it looks darker, but
Compared to the muscle.
yeah, compare it to the skeletal muscle. So you compare it to the skeletal muscle, and you see that's darker than skeletal muscle. So that kind of telling you that this is dropping out its signal. This is another young patient. This is a 12-year-old with myasthenia gravis, right? So here again, there's an anterior mediastinal mass, but there's something about the shape of this that's a clue as to what this represents. And what is that?
draping over.
It's draping over, it's kind of banana-shaped, right? So that suggests that rather than a thymoma, so 12-year-olds don't get thymoma, first of all. It's not, even in myasthenia gravis, it's not, thymoma does not occur in children. But given this shape, again, you're going to be thinking about also thymic hyperplasia, right. This represents diffuse enlargement of the thymus. That's another example of thymic hyperplasia. And then the post-phase imaging can be very helpful as it drops out in signal, telling you that this contains thymic tissue, right? So that is thymic hyperplasia. So here's another patient with myasthenia gravis. This one had the smaller lesion there. And then we can see here, it's a little bit harder to see. There's the arrow, there's the in phase, there's the out of phase. So you can see that that area is dropping out its signal, okay? So again, is another example of thymic hyperplasia, okay, in somebody with myasthenia gravis. This is a 46-year-old woman with chest pain, tachycardia, dyspnea. Of course, she shows up in the ER and she gets a CT scan for PE, right. She gets a CT scan for PE. So here are the findings on this CT scan for PE. What are the findings?
Big thyroid.
Yeah, so one, your eye catches the thyroid, it kind of looks enlarged. And second, given the topic of the lecture, you might also look at, right, there's an anterior mediastinal mass. Here it is, and there's a nice coronal reformat of the anterior mediastinal mass. So looking at the appearance of the anterior mediastinal mass, you picked up on the big thyroid. What are you thinking about here? Well, what is it about that thyroid that can lead to chest pain, tachycardia, and shortness of breath?
Graves.
Graves' disease, yeah. This patient has Graves' disease. Can you put that together with what you see here? So what is this? That is also thymic hyperplasia. Is Graves' disease associated with thymic hyperplasia?
Yes.
The answer is yes. Yes, Graves' disease is also associated with thymic hyperplasia. So there are two forms of thymic hyperplasia. There's true thymic hyperplasia where the entire gland enlarges and you get diffuse enlargement of the gland. That is associated with these things, Graves' disease, thymic rebound, etc. So it can also occur, rebound hyperplasia also occurs after treatment for acute illnesses. It's more common in younger patients. So you'll see a diffusely enlarged thymus that preserves its normal shape. So this appearance of the thymus kind of draping down there over the anterior mediastinum, over the heart, is very typical of thymic hyperplasia. There's thymic lymphoid hyperplasia. This can give you more focal abnormalities in the thymus. This can mimic a thymic mass. This also is the type that can occur. The other kind can also occur in patients with myasthenia gravis, but this can also occur in patients with myasthenia gravis, where they'll get these nodular areas of thymic hyperplasia within the thymus, and this can also be associated with other autoimmune diseases. So here the thymus might be diffusely enlarged, or there might be a focal enlargement in the thymus, which can mimic a thymic tumor. So here's diffuse thymic hyperplasia. We've seen that already. And then again, the post-phase imaging can help you if you're trying to differentiate thymic hyperplasia from tumors. If it drops out its signal, that helps to tell you that you're dealing with thymic hyperplasia, not a tumor, as opposed to here's a case of non-Hodgkin's lymphoma that does not drop out in signal. So there you're going to be thinking about malignancies. For quantitative measuring, there is this thing called the signal intensity index. So if you like numbers, you actually measure the signal there. You put an ROI on your area that you're trying to evaluate, and then you plug it into this formula. The in-phase numbers, you take the out-of-phase number, subtract the in-phase number divided by the in-phase number times 100%. So it's kind of telling you how much the signal is dropping out. So if it drops out more than 20%, it's benign. 9 to 20%, you're in the indeterminate range. You get follow-up study. And if it's less than 9%, then you're concerned that it is not benign. So that's a quantitative way of doing it, although usually we just eyeball it to figure it out. Okay. All right, so here we have somebody with this anterior mass, and we have evaluated it with MRI. We have T1, T2, pre-GAD, post-GAD. There's a subtraction image. What can we say about this lesion?
not enhancing and there's signal dropout.
Well, how do you know there's signal dropout? Have I shown you in phase and out of phase?
Oh, sorry.
But you're right, there's no enhancement. Now, with MR, sometimes it can be hard to tell when you do pre and post if there's enhancement in there, and that's where the subtraction images can help you. All right. So you do the subtraction images that shows you that there's no signal in there. So there is no enhancement. It's normal to have this little bit at the edge. That's an artifact from the subtraction itself. Okay. So this mass is not enhancing. What can we say about it? What can we say about it based on the T1 and T2 weighted images?
Fluid intensity.
By the way, it measures, yeah, so it's following fluid signal, but it measures higher than fluid, and you can't see the number there, but it's like around 45 or 50. So it measures higher than fluid attenuation on the CT, which raised the concern that this was a solid lesion, right? So it is bright on T2, kind of acting like fluid, no enhancement. Our interpretation of this is that this represents what?
Cyst.
Yeah, so this is a thymic cyst. And thymic cyst can be high attenuation on CT scan, even non-contrast or post-contrast. You wouldn't expect enhancement of these on CT. But they can have proteinaceous fluid. So on CT, they can mimic solid lesions. And this is where MR can be helpful to differentiate solid from cystic lesions. So the most important characteristic of that is that there's no enhancement in the lesion. And these also tend to be bright on T2. They can be higher than simple fluid on T1 because of the proteinaceous contents. Here's another case where you have this low attenuation anterior mediastinal mass on T2. It does have this bright area. There's your post-scat image. What do we say here? So what's different about this? There is rim enhancer, right? There's thickening of the wall, and this is also multiloculated, right? So can we say that this is a simple thymic cyst? No, in this case we don't. So in this case we can worry about neoplasm. And what are neoplasms? What are primary mediastinal neoplasms that can present as cystic lesions? What are they? Which ones can do that? Well, you can have cystic thymoma, and you can also have germ cell tumors. Malignant germ cell tumors like seminoma can also sometimes present as cystic lesions. So that has to be considered here, and this was a cystic thymoma. Okay, so if it's multiloculated, if there's thickening of the walls, we can't assume that it's a benign lesion. So here we do need to be concerned about malignancy. Here's another very nice example: cystic lesion there on the CT scan. Although even on the CT, you can see there's a little bit of nodular enhancement over in the periphery of this lesion. So you have to be concerned about malignancy in this case. And here's the PET scan. You can see the metabolic activity there. So this was also malignancy, right? So cystic tumors, like you can have cystic thymoma and cystic seminomas in the anterior mediastinum. So thymic cysts, they can be congenital or acquired. Acquired cysts can be from inflammation, cystic degeneration, sometimes after treatment for lymphoma. You can also have residual cysts within the anterior mediastinum. So if it's a simple thymic cyst, it might measure fluid attenuation. There's no enhancement, has a very thin wall. Okay, and then that's the appearance of a non-neoplastic thymic cyst. If there's concern, you can do a follow-up MRI, again looking for regions of enhancement within the lesion. So this is the appearance of a simple thymic cyst there in the anterior mediastinum. So here's another patient who has a mass here that's in the right cardiophrenic angle, okay? And then here's the appearance on the CT. So what do we have to say about this?
Looks mostly fatty.
It looks mostly fatty, right, but there are some soft tissue elements within the lesion. So there are two things, or maybe three, that would enter the differential diagnosis with this. What are those three things? What? Liposarcoma has to be considered here, right? So you can have a low-grade liposarcoma that can present as a predominantly fatty tumor within the anterior mediastinum. What else?
Thymolipoma.
Thymolipoma, right, that's the other thing, and this was a thymolipoma. There's a third thing that you also have to consider, and that's why it's important to look above and below this level. What's the third thing that we're going to be thinking about? Diaphragmatic hernia. What do we call them in this location?
Morgagni.
Yeah, Morgagni hernia, right. So that's another thing to consider here. This was a case of a thymolipoma. So these thymolipomas can grow to very large. They usually don't cause symptoms. And they do have to be removed because, again, the concern is that, they can't, you might be dealing with a low-grade liposarcoma. All right, they're soft and pliable. Sometimes even on decubus imaging, they might move. They might be connected to the thymus by a pedicle. So these tend to be large masses in the anterior mediastinum that might change with position. On CT, they're predominantly fatty attenuation, and they may have these areas of, they may have soft tissue elements within it. Okay. Here's another anterior mediastinal mass. There's a finding on the second image. What's the finding on the second image?
Bilateral adrenal gland thickening.
Yeah, so you have bilateral adrenal hyperplasia. How do you put that together with an anterior mediastinal mass?
Thymic carcinoid.
So thymic carcinoid, so this can give you adrenal hyperplasia. So if we have this combination of an anterior mediastinal mass with adrenal hyperplasia, we think of thymic carcinoid tumors. 50% of these are functionally active producing ACTH that can cause Cushing's syndrome. Interestingly, carcinoid syndrome does not occur with thymic carcinoid tumors, and 20% associated with the multiple endocrine neoplasia syndrome. So these can be aggressive, so sometimes they can present with metastatic disease. So if we have an anterior mediastinal mass here, these also tend to be vascular carcinoid tumors. If you have an anterior mediastinal mass associated with adrenal hyperplasia, a patient who's Cushingoid, then we can think of carcinoid tumors of the thymus. Okay, so again, you know the drill, the theme of the conference. This patient has a
Anterior.
large, bulky anterior mediastinal mass. Here's the CT on this case. There it is, big, bulky anterior mediastinal mass. But there are some findings here where you might be a little bit more specific about what this might be. So
Axillary lymphadenopathy.
you have axillary lymphadenopathy, right? So in addition to this bulky anterior mediastinal mass, we have lymphadenopathy elsewhere. So given that combination, you're going to think about what? Lymphoma. And what's the lymphoma that you think about that's associated, that gives you these bulky anterior mediastinal masses? The most common is Hodgkin's, right? So it's the case of Hodgkin's lymphoma. Bimodal peak distribution, young people, older people. Most patients will have mediastinal adenopathy, most commonly involving these anterior mediastinal nodes. So 98% of patients with intrathoracic lymphadenopathy from Hodgkin's disease will have involvement of those nodes, right? So that's a very typical appearance. It tends to spread by contiguity so that adjacent node groups may also be enlarged. The different cell types, the nodular sclerosing is the most common to involve the anterior mediastinum and also the thymus. Their staging, here I won't go over this with you, so you have this in your handout as far as the staging for Hodgkin's. So this tends to present as a large, bulky anterior mediastinal mass. So large, bulky anterior mediastinal mass, young person, first thing on your list is going to be Hodgkin's lymphoma. And look for lymphadenopathy elsewhere. Whenever you have lymphadenopathy like that, you pretty much always have lymphadenopathy elsewhere, maybe in the at the cervical inlet or in the neck. Look there. Also axillary nodes, very common. And nodes are usually homogeneous, but sometimes they might be cystic and necrotic. After treatment, they can be necrotic. They can also develop calcifications. If there's involvement of the lung parenchyma, it tends to spread from the lymph node to the adjacent lung parenchyma, as opposed to non-Hodgkin's lymphoma, where you can have parenchymal masses that are separate from the lymphadenopathy. Okay. So speaking of non-Hodgkin's, this can also involve the mediastinum. Disease is probably systemic at presentation. Non-contiguous spread is common with non-Hodgkin's lymphoma, so you can have skip areas where you have lymphadenopathy in the chest, and then you might not see lymphadenopathy until you go, way further down in the abdomen. The staging is the same as Hodgkin's and similar imaging features. There is this variant called primary mediastinal large B-cell lymphoma of non-Hodgkin's that is associated with these bulky anterior mediastinal masses. Also think of this in patients who are HIV positive. Those patients are also at increased risk for lymphoma, usually non-Hodgkin's lymphoma. So these can present as these bulky anterior mediastinal masses. This was an example of non-Hodgkin's lymphoma presenting there as a bulky anterior mediastinal mass. Okay? Follow-up after treatment for lymphoma. Often after follow-up, patients have residual masses, even though the masses do not contain do not contain active tumor cells. So that is called sterilized lymphoma, and that's why these patients are followed with PET-CT to look to see if there's any active metabolic activity within those areas. So what's left behind might be fibrous tissue, but on CT just looks like soft tissue. So before therapy, after therapy, you can see there's residual soft tissue there in the anterior mediastinum. So does that contain residual disease or not? This is where PET-CT is very helpful. So you look for activity within there, and you can see that there's no activity there after therapy. So PET-CT is used to follow these patients to look for active disease. Other things that can occur, you can get recurrence, especially in the cardiophrenic angles, right? So a patient with lymphoma presents in a follow-up with a cardiophrenic angle mass, that can be recurrent lymphoma, right? So that can occur as an example. All these nodes in the cardiophrenic angle from recurrent Hodgkin's lymphoma in that particular patient. Okay, the findings on this chest radiograph. What do we have? Well, starting with the theme of the conference, we have, yes, again, we have a large anterior mediastinal mass. What else do we have? You have multiple lung nodules. So do we think this person has benign disease or malignant disease? Malignant disease. Now, you're sitting in the reading room, you come across this chest x-ray, right? Tell me what differentials go through your mind. What's the first thing you might think about? Reading that in the reading room, there it is, there's a chest x-ray. So what's the first thing you might consider here? That's not the first thing you're going to consider. Lung cancer is the first thing you're going to consider. What kind of lung cancer? What's the most aggressive? Small cell, right. So small cell lung cancer might be the first thing you're going to consider. What else would you consider? Go ahead. That's it? That's the only differential you have is lung cancer? Could it be metastatic disease from somewhere else?
Yes.
Sure. So it could be metastatic disease from anywhere, right? Renal cancer, colon cancer, breast cancer, right? Especially if it's a woman, right? So of course that has to be in the differential diagnosis. What else is in your differential diagnosis?
Is that cancer or just?
Do you think this is benign?
No.
Okay, so what else is in your differential diagnosis? Well, usually, like back when I was a resident, if you were being tortured with a case and the question was, what else could it be? The thing is, you sit there, look up in the air, stare for a few seconds and say, it could be lymphoma. And that always works. All right, so no matter, regardless of what it looks like, right, you look up and you say, it could be lymphoma. Yeah, that could be, right?
Terrible lymphoma specifically.
So lymphoma, well, except in this case, remember the nodules look separate from the lesion itself, so maybe non-Hodgkin's lymphoma, right? But lymphoma would also be considered in your differential diagnosis. I mean, if this is lymphadenopathy there in the anterior mediastinum and you have all of these lesions, okay? Now on the CT, right, we do have these nodules within the chest. We have this large anterior mediastinal mass. Considering all those things in the differential, you brought up one other possibility, which was malignant germ cell tumor. What kind of tumor? Now, why would you consider that in this patient? The most important reason why you might consider that in this patient is what? Anybody? It's a male, right? It's a male patient. So you have a male patient with an aggressive anterior mediastinal mass that looks like it's metastatic, right? So lymphoma might be the first thing. It helps the age. This was a younger person. So lymphoma might be the first thing you think about. But whenever you have an aggressive anterior mediastinal mass in a male patient, another consideration is a malignant germ cell tumor. The most common of those is seminoma. This is primary in the mediastinum. This is not metastatic disease from the testicles, all right? So what business does germ cell tumor have occurring in the anterior mediastinum? Why does that happen?
Some embryology.
So tell me, what is it about embryology? The interesting thing is, so this is embryologically, the germ cells start in the middle, and then they migrate, right? They migrate to where the gonads will form, but you can have germ cell rests. You can have germ cells that are left behind in the middle. And that's why anywhere in the middle of the body, you can have germ cell tumors, pineal, corpus callosum, retroperitoneum. Anywhere in the middle of the body, you can have germ cell tumors. And those occur from germ cell rest. That can also occur here, so seminoma. Aggressive anterior mediastinal mass, young person, young male, in addition to lymphoma, include malignant germ cell tumor. So these malignant tumors, germ cell tumors, tend not to occur in females. They're almost always male patients. Another patient here, where's the mass?
Anterior mediastinum.
Surprise, surprise, anterior mediastinum. There's another feature here that's helpful. What is it? In terms of telling me what this is. What's the other feature that we see? See anything on the lateral view? There's a calcification. So what are you thinking about? Yeah, so another germ cell tumor, and then here you might think about what is the most specific feature for teratoma here?
There's fat.
Fat, right. So fat in the lesion. So if you have fatty foci within the lesion, fat, calcification, fluid, those three things point to teratoma, but fat tends to be the most specific feature for teratoma. We see that in the anterior mediastinal mass. So these mediastinal germ cell tumors arise from rests. For benign tumors, males equal females, but the malignant tumors are almost always in males. The most common malignant one is seminoma, although you can have non-seminomatous malignant germ cell tumors also. So mediastinal teratomas, most of these are benign, but some of them can still contain malignant elements. That's why they should be removed. And most patients tend to be young. So pancreatic tissue or intestinal mucosa within the tumor secreting digestive enzymes can cause rupture into the lung airway, pericardium, or pleura. Sometimes there can be hair in these that can get into the airway. So coughing up hair can be a pathologic finding of this. So trichoptisis, coughing up hair, is a rare but characteristic symptom of ruptured mediastinal teratoma. So soft tissue, calcium, fat. Fat is the most specific feature and fluid within these lesions. 75% have fat, 50% have calcification. A small percentage can have a fat fluid level, which is a very specific feature for these teratomas. Right? So if you see fat within the lesion, calcification within the lesion, then we're dealing with these germ cell tumors, teratomas. Another example, some fat in the lesion, some fluid there within the lesion. And here's a nice fat fluid level, right? So that's a dermoid there. So that is also a germ cell tumor. The malignant ones, almost always males. Seminomas are the most common. These can also present as these large, aggressive anterior mediastinal masses. 10% of might have a positive pregnancy test there. Okay? So solid, sometimes like that, solid anterior mediastinal mass in a male, in addition to lymphoma, thymoma. You also can think about malignant germ cell tumor. Okay? This one's very aggressive. Another example of a seminoma, very aggressive anterior mediastinal mass in this young man. That was a seminoma. Sometimes these can be cystic. So if you have a multiloculated cystic tumor, enhancement, thickening of walls, that can be a cystic variety of these seminomas.
We should also consider like TB there, like TB lymph nodes. Like,
Yeah, so you for TB that would also enter your differential diagnosis if it looked like lymph nodes, right? But these don't really look like lymph nodes, right? But if they look like lymph nodes with peripheral enhancement, low attenuation centers, then of course you're going to be thinking about tuberculosis. Right? The non-seminomatous malignant germ cell tumors, these are the types. They can be associated with Klinefelters, okay? They can produce HCG and AFP, alpha-fetoprotein. Right? So as an example of one of those large, heterogeneous, aggressive-looking mass. The mass in this patient is located where?
Cardiophrenic.
The cardiophrenic angle, there's a differential diagnosis for cardiophrenic angle mass. That differential is
Cardiophrenic cyst.
pericardial cyst. What else? Yeah, sure. Morgagni hernia can also occur there. We discussed also lymphomas, if that's lymphadenopathy from recurrent lymphoma. Okay, this turns out to be a pericardial cyst. So it's a fluid attenuation lesion that is in contact with the pericardium. These do not communicate with the pericardium. So it's like a loculated collection of fluid. That's a pericardial cyst. So it results from anomalous outpouching of the parietal pericardium. They can occur in either cardiophrenic angle, usually do not communicate with the pericardium. Another example, this mass there in contact with the heart on CT, we can see that that also turns out to be a pericardial cyst. So your differential diagnosis, fat pad, is also something that very commonly occurs here. To differentiate a fat pad from a solid lesion, the fat pads are a little bit more lucent on the chest radiograph. You can see the blood vessels very nicely through the lesion there on the chest radiograph. And on the lateral view, they tend to have this kind of triangular appearance on the lateral view. That's an epicardial fat pad. If there's a question, very easy diagnosis on CT, right, when we're dealing with these fat pads. Okay. Here's a large mass here. Looks like there's a little bit of air in it, right? What do you think that turns out to be? Yeah, that's a Morgagni hernia. So there's colon extending into that mass. Okay, there's another patient, anterior mediastinal mass. There are some other findings here. What are the other findings?
The expansile lesion in the humerus and bladder.
Yeah, so there's an expansile lesion in the humerus there. On this particular image, what's the finding? That right rib, expansile lesion in the rib, and on the last image you have renal stone. Put them all together, what do you get? Anterior mediastinal mass with expansile rib lesions and renal stones. Yes. So you have, so these are called what? These are brown tumors, right? So ectopic parathyroid adenoma, right? So that can be associated with brown tumors and of course the renal stones from the calcium problems with that. Okay. So usually you don't find these accidentally, you find these because you're looking for them. They know the patient has hyperparathyroidism, so they're looking for an ectopic parathyroid adenoma. So ectopic parathyroid adenoma is 50% of patients with persistent hyperparathyroidism after surgery will have mediastinal ectopic parathyroid adenomas. 2/3 in the superior mediastinum near the tracheoesophageal groove, 1/3 in the anterior mediastinum within the thymus. So these tend not to be very large lesions. They do tend to be vascular, so they will enhance with contrast. And of course, the way we look for them now is with the Sestamibi study there to look for these ectopic parathyroid adenomas. Okay, so we can do that. They're very bright on T2. So they're very bright if you happen to do MR on these lesions. They're very bright on T2 weighted imaging, ectopic parathyroid adenoma. So this patient has this kind of cystic mass at the thoracic inlet. Okay, notice that it is kind of insinuating here between the blood vessels like that. All right? So that's characteristic for a certain type of lesion. And the findings here on the MR, this T2 weighted MR, are also very helpful. So what are we dealing with here? Lymphangioma. So what are the findings on the MR? Septations, right? So these tend to be septated lesions. So that's a lymphangioma. So these lymphangiomas are congenital malformations of the lymph channels. Most commonly occur in the neck, but they can extend down to the mediastinum. Sometimes they might be just located there near the thoracic inlet at the mediastinum, in the mediastinum. So these can occur as lesions like that near the thoracic inlet, and the clue is that they're fluid in attenuation, they might have cystic areas or septations, there might be septations within it, easier to demonstrate with MRI when you're dealing with lymphangioma. Big anterior mediastinal mass in this case. Sultan, you've received a request for a biopsy, and the tech is asking you what position would you like the patient in on the CT table. What are you going to say?
I say, let's get a CAT scan first. I don't know what we're looking at.
And you want a CAT scan with contrast, and it shows you that this represents what?
Definitely don't want a biopsy.
So what is this?
Aneurysm.
It's an aneurysm, but it has this very irregular appearance, right? So this turns out to be a large pseudoaneurysm. So when you have aneurysms like that in unusual location, especially when it's large like that, what do you think of as etiologists?
Mycotic.
Mycotic aneurysm, right? So remember that aneurysm can occur also anywhere in the mediastinum. So you want to make sure that you're not dealing with an aneurysm. I mean, you can imagine if you're doing a biopsy on non-contrast CT, you might not, don't stick a needle in this because it might not be obvious that this is connected to a vascular structure. So always consider aneurysm in your differential diagnosis for any of the mediastinal compartments, especially if you're asked questions about biopsying the lesion. Another thing to think about, so this was read as an anterior mediastinal mass, this thing here, it turns out that if you had to decide where the center of this is, it's actually closer to the lung than it is in the mediastinum. This turns out to be lung cancer invading the mediastinum. And lung cancer invading the mediastinum is more common than primary mediastinal masses, okay? So also in your consideration when you're dealing with mediastinal masses, always consider, is it possible that we're dealing with a lung cancer that is extending into the mediastinum rather than a primary mediastinal mass, all right? So we can decide on what these are based on CT appearance, whether it's solid, fat, or cystic. If it's predominantly solid, thyroid mass should connect to the thyroid lymphoma, look for adenopathy elsewhere. Thymoma associated with myasthenia gravis seminoma, we think of that in young males. If it's fat, thymolipoma is predominantly fat. Teratoma has foci of fat in it, often associated with calcifications and fluid. If it's cystic, thymic cyst, the simple ones, not multiloculated, thin walls, no nodularity. You can have cystic germ cell tumors. So if it's multiloculated, if there's enhancement in the wall, you're going to think about tumors. Pericardial cysts contact the pericardium. Lymphangioma, usually near the thoracic inlet, we look for septations within the lesion. All right. So that is our discussion of anterior mediastinal mass.